Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today's guest is Jing Li. She is currently a cardiac sonographer at Stanford Medical Center over the past 6 years of experience in echocardiography. She was originally trained and worked as a physician in China, which gave her a strong clinical foundation for ultrasound. In the US, she worked at major centers like Tufts Medical Center and Beth Israel Deaconess Medical Center. She performed both routine and advanced echocardiographic studies, including TAVR, the TAVR, HCM, LVAD, and stress echo. Her physician background, combined with her experience at high-volume academic centers, allows her to deliver high-quality imaging and contribute effectively to patient care. She enjoys golfing and cooking, and she is in the Advanced Practice Sonography program with Dr. Joy Guthrie. Please help me welcome Jing Li. I met Jing Li when I have recently started a program in Advanced Practice Sonography, and Jing Li is a part of that as well. And so we met, and she's been a wonderful addition to my life, and is fun to be around. And I'm happy to introduce her and let her share some of her background. And then our topic today is hypertrophic cardiomyopathy. So we're going to talk about that. But first, Jing, thank you for coming on. And second, tell us a little bit about yourself, how and why you got into ultrasound and why you stick around with ultrasound, why you keep going with it.
Okay, hi everybody. First, thank you, Debbie, to invite me. This is my honor. My full name is Jing Li. I'm original from China. When I was in China, I was a radiologist. It's like ultrasound physician. So I already know what I'm doing. And after that, I decided to come to the United States because I want learn more and see more interesting cases. So I went to school in here and do everything again. Finally, graduate, got a certificate, become a sonographer. So I choose the cardiac because I think cardiac is the most challenging one. And
Yes.
then, yes. So it's kind of very fun because like every day's case is different. So I feel like make my life more interesting.
Yeah.
Yeah.
So I think it's interesting, for most people in America to understand that you were a physician, a radiologist, you said, in
Yes.
China, but you chose to come here, and you can't be a physician without going through the whole education process, like, right? Medical school and all that kind of thing. Is that correct?
Yes, it could, but it took so long because you need to go to the medical school or you need to take the board exam and then become residency again, do the 3 years residency and become like cardiologist fellow for another 4 years
Yeah.
and then become the physician. That's like too much for me. You need to
Yeah,
keep
another
life
8
balance.
years, right?
Yeah.
So
So I'm
how
already
long
39, so I don't want to do that.
so how long was it to become a radiologist in China?
Oh, it's way easier compared here. So it's like after we graduate from high school, we can directly go to the medical school. So you don't
Oh,
have to get a bachelor degree first
okay.
and then go to the medical school, become the doctor. You know what I'm saying?
Okay.
Yeah. So it's like after graduate high school and then go to the medical school, you can spend like 5 years. After 5 years, you can take the board exam, become the
Okay.
physician. Yeah,
Okay.
but since now it's more competitive compared 10 years. So if you want to go to like very big hospital like in Shanghai, Beijing, you have to at least get doctor degree too.
Okay.
Yes, but for my hometown, it's kind of small town.
Yeah.
Actually, the requirement is not high, not that high compared to big city. So
Okay.
you still can like after you graduate from a bachelor degree, but it's from the medical school and pass the board exam, become physician there. That's
Okay.
what I did. Yeah.
Okay. Awesome. Awesome. Well, welcome to the United States. I'm
Thank you.
glad to have you in ultrasound. I think it's interesting that you chose ultrasound as a physician. Um,
Mhm.
so I think, our field as ultrasound is so pivotal to a lot of patients' care, right? We
Yeah.
really, what our pictures really do dictate the care that our patients are getting, right? And
Yeah.
so I would imagine that's one reason why you chose ultrasound. Is that true?
Yes, I agree. And it's like, I can like, do you mind I told you like something like different between the United States and China? Like the both side the system is very different. So we have a lot of patients. So when I was in China, I scan at least 50 patients per day. But now as sonographer, I only scan 7 patients. You know,
Wow.
the cost is we spend more time and we can see more detail, right?
Uh,
But but in China, it's like because I'm already physician, I directly scan. I do not record picture. I can
okay.
directly tell the detail. What I see, directly tell the patient. And then here has another person sitting next to me, they type what I saw.
Okay.
And then after the study done, we print out the result. Patient can hold the result, go to see their private doctor directly.
Okay.
So it's like more efficiency, like faster, way faster than here.
Right.
But the thing is, what if it's complex cases? You need more time. But since
Right.
we are so busy, we not have that much time to scan like one patient. So
Okay.
yeah, so I feel like both side they have their good side and then yeah.
Pros and
And
cons.
yes, I
So in America, we're probably more thorough, do you think,
mhm.
in
Yeah,
our exams? Excuse me. But it just takes longer for the patient to get the result. Is that correct?
yeah. Mm-hmm.
Yeah.
So if you are the patient, what do you like? If you are the patient, you prefer like get the result way faster, or you would rather to wait? Yeah.
Um, well, I think as a patient, I would rather have a more thorough exam
Mm-hmm.
and
Mm-hmm.
have to wait a few days on the result. Uh,
Yeah.
and I think in America, we're getting better at getting
Mm-hmm.
results to patients faster, right?
Yeah. Yes.
Especially if they're critical results, you know.
Mm-hmm. Mm-hmm.
So I don't know. But, America is the only thing I've known. So I haven't experienced life in a
Mm-hmm.
different country. So I don't, it would be wonderful to, have the result in my hand and then be able to go see another doctor and get into the other doctor right away. Right.
Yeah. Yeah.
Which doesn't happen here, obviously. Um, so I don't know, right? I don't know what I would prefer because I've only known one way, right?
Mhm, mhm. Yes, you're right.
So it's interesting, but I like the fact that the physician does the exam and dictates it to someone who's typing it out.
Mm-hmm.
I think that's a pretty efficient way to do things, you know?
Mm-hmm. Mm-hmm.
Um, so yeah, maybe we can learn something, Things a little different here. Who
Yeah,
knows?
it's very different.
So, thanks again for joining and talking about this really important topic of hypertrophic cardiomyopathy. I did do a little research and on the topic
Mm-hmm.
and mostly let's see in the before echo really was used very prevalently. Holcomb was just identified as a largely just through physical exam and angiography or a cardiac catheterization, right?
Yep.
They are showing dynamic subaortic pressure gradients. And so this disease was initially understood mostly as a hemodynamic obstruction syndrome rather than a broader genetic myocardial disease concept that we use today, right? So in the 1960s and 70s, when M-mode came out, that kind of changed everything. And we could see asymmetric septal hypertrophy and the systolic anterior motion of the mitral valve. So that M mode really helped change the history of this disease and at that time. And then in the 1980s, we had the 2D echo, which really broadens more of the understanding. And we as clinicians could understand and move beyond a single ultrasound line and better visualization of the full pattern of hypertrophic or hypertrophy. And so this helps show was not a uniform disease, but echo revealed different morphologic pattern, and it was better defined septal thickness, mitral valve abnormalities, papillary muscle involvement, and the relationship between the hypertrophic septum and the left ventricular outflow obstruction. And that was in the 80s. So then we jumped to the 90s, 80s to 90s, and Doppler came into play. And so Doppler helped make the Holcomb physiology not just anatomic, but it also helped us measure the velocities and estimate the LVOT gradient in real time. So now we're in our 2000s and the 1990s to 2000s, and echoes become the frontline test for Holcomb and the follow-up after treatment. And so we've gotten much more detailed and can really follow the disease process here in the 2000s. But now it's 2026 and we have this multi-modality era, but echo still remains our first line. So now we can use the 2D, the Doppler, different kind of maneuvers, contrast, strain imaging, stress echo. So all these things are what we'll talk about today in Jing Li's presentation here or conversation. And now we have a lot of key factors and ways to really identify this and monitor it as patients move forward in their life. And also now I think we've also been able to understand it more as a genetic disease, correct?
Yes.
Instead of just a disease process. So I think that's a little bit of the background of Holcomb and where we have been and where we're going. And now, so tell us, I guess we need to start with the definition of hypertrophic cardiomyopathy. Can you tell us a little bit about that?
Yes. So the hypertrophic cardiomyopathy, which is HCM, the disease is in which the heart muscle becomes thickened, but especially it's asymmetric thickening of the heart muscle. So usually if the number is greater than 1.5 centimeter, or the patient who has like family history, and then the interception is thickened than 1.3 centimeter. That's what is the definition of.
And so this is pretty common then, right? Because a lot of people have histories of this.
Yeah, it's kind of like the second most common type after
Okay.
dilated cardiomyopathy. Yeah.
So we're talking about like 1 in 500 people then, right?
Yeah, in the United States. And for HCM, like under diagnosis, because they are asymmetric. And the most common happen in the United States is sudden cardiac death in young patient.
Wow.
Yeah.
That's pretty impressive, right? Like
Yes.
sudden death, like you're in college and all of a sudden somebody dies. That's kind of scary.
Yeah, especially the sporter,
Yeah.
the young patients. Yeah.
Yeah. So tell us about the different kinds of hypertrophic cardiomyopathy.
So it's most the common one, no, most the severe one or how to say, no, it's like the most important is obstruction of the HCM. That's one type. Another type is HCM without obstruction, and another type is apical HCM. It's
Okay.
mostly see the cases from I mean, apical HCM.
So tell us a little bit about each one of those. The HCM with obstruction, how is
Okay.
that defined?
So for HCM with obstruction, so the heart has thickening walls, and the mitral valve blocks the blood flow out of the left ventricle. So on the echo, we can see the systole anterior motion of the mitral valve. We also call SAM. So when the LVOT, which left ventricle outflow tract gradient greater than 30 millimeter of mercury, we will call obstruction. So if it's greater than 50 millimeter of mercury, we consider patient need to have surgery intervene.
Awesome.
Yeah. So for the HCM without obstruction, which means they have thickening walls, but the mitral valve does not block the blood flow out of the left ventricle. So for the apical HCM, it's like the wall thickening only locate isolated to the apex. But for that case, the most important thing for sonographer, we need to rule out the patient do not have aneurysm of the apex. That's very important.
That the patient doesn't have any reason for,
Aneurysm, apical aneurysm
oh,
for the
aneurysm. Okay.
yeah, yeah.
Aneurysm.
Yes, because since the muscle is isolate to the apex, so the pressure is very high. It's
Okay.
patient gonna have like very high chance, has very tiny aneurysm at the apex. So we need to use contrast, or when you scan it, especially for the new sonographer, when they scan the short axis of the view, after the papillary muscle level, usually they do not continue slide down. They directly jump to full chamber. But I highly recommend you keeping slide down your transducer. Even you see, especially after you see very thick wall, after that continue sweep down, the wall gonna become smaller because you're close to the apex. And
Okay.
then don't stop, continue until you see nothing because the small aneurysm could be show up after you scan that part.
Okay.
Yeah.
Okay. So that's important to know, is to make sure you're looking for that aneurysm and being thorough enough to sweep all the way through that apical portion.
Yes.
So what's the secondary mitral valve regurgitation from the obstruction?
So the secondary is mitral regurgitation from the obstructive HCM because we know uh, it's like when the mitral valve block the blood from the left ventricle, so the valve is kind of like dragging up because the blood was sucked out through the LVOT. So the
Okay.
blood only have two way. One they go to the LVOT, another one they go to the left atrium. Then we can see the mitral valve regurgitation. And for that, mitral valve regurgitation is kind of different compare functional mitral valve regurgitation. The profile looks very different. That's the
Okay.
difference. Yes.
Right. Right. So that would be classified as totally different disease process then, right?
Yes.
So with obstruction, tell me some of the things that you see with obstruction.
With the obstruction, what I see. So usually we go to the peristernal lung axis, and then I saw a lot of case, no matter the new sonographer or senior sonographer, we have like kind of similar protocol.
Right.
Especially when oh, sorry, I forgot to mention because I am from Boston. So I have been work at Tufts Medical Center for a long time, like almost 4 years. So
Okay.
I had a lot of HCM cases maybe 3 or 4 cases per day. So
Okay.
I have been saw a lot of cases. So when I check some sonographer picture, when they zoom up the mitral valve, they only focus on the mitral valve. They do not use the zoom, include the into interventricular septum. You have
Okay.
to do that because when you put the color on, you need to show, or no matter 2D or color, you need to show the reader the mitral valve touch the septum or not. If you do not include the septum, you miss that part. That is very important for HCM patients.
Okay.
Yeah. So let's go back to see the what the classic HCM with the obstruction, what I see. So
Okay.
at the personal long axis, definitely you will see the same systole uh, anterior motion of the mitral valve. So when
Right.
you the cursor cross the mitral valve, on the end mode, you will see the anterior leaflet will touch the septum
Okay.
during the systole.
And that's in your classic.
Yeah, in the classic. And then when you go to the five chamber and the three chamber, you will also see the anterior valve touch the septum during the systole. And when you put the color on for the classic HCM with obstruction, you will see very, very obviously turbulence show up at the LVOT, and also you will see very significant mitral valve regurgitation.
Perfect. So it's important to get your angles correct when doing that, correct?
Yes. So for the angle, when I was at Tufts, so we are not the only, the ideal position is as the patient turn left toward us, right? But for HCM patient, I'm not only do that position. I even ask them supine because it's hyperdynamic. You will
Right.
never know, right? Our
Right.
goal is find out the highest velocity. If you can find it, everybody is happy, but nobody care what position the patient is,
Okay.
right? So try even when the patient lay flat, if you can get a better angle, you might get a higher velocity.
Okay.
What than when patient lay on the left side? That's what I got my experience.
Ah, nice. Little tip there.
Yes. And also another tip is for like the significant obstruction of the HCM. We usually make the picture in the center of the screen, right?
Right.
But when you do in the center of the screen, when you put a cursor, especially continuous wave, because it's very high for the gradient, right?
Right. Right.
You cannot get away from mitral valve regurgitation and the LVOT gradient. They are combined together,
Okay.
especially for severe MR and a severe LVOT obstruction. So for that way, usually I try to get the picture on the very left side of the screen.
Okay.
And then the heart is like lay down like 90 degree, like 30 degree, like that.
Yeah.
So when you do the cursor, you kind of can get away from the MR. Then you
Ah,
that way, yeah, you might got a better gradient.
nice. So you kind of lay it out flat so that you
Yes,
get the best.
yes. Well, try to get away from the mitral valve regurgitation because some sonographer or some people they might mix up. They think that is obstruction gradient, but it's MR.
Ah, okay.
Yeah, because we all know for the MR, it's like right after the Q wave, R wave, right? Right next to the R wave is MR. But that most likely is for functional mitral valve regurgitation. But
Right.
for the secondary mitral valve regurgitation from the HCM obstruction, the mitral valve regurgitation might not that completely. It might not that nice.
Okay.
Yeah, so that's the tricky one can mix you up.
So what are some of the treatments for that then? How do they treat that?
So you mean treat the LVT obstruction? What do you
Yeah.
mean?
Yeah.
So you mean when you see the profile or
So does the patient just take medicine to help reduce that thickness, or do they have
you see
surgery or?
the treatment. Sorry, I didn't know. So for the treatment, people might have the like myectomy, which means they had an open heart surgery. They cut the thickened wall
Okay.
become thinner and then make the LVT truck is wider. So that's like before. But nowadays, I think they have new medicine now because I work at Stanford now.
Okay.
We had tons of cases. The patient coming, they have like a new medicine treatment track. So they come back every month, and then after every 3 months, they come back to see after they took that medicine,
Okay.
if their obstruction gradient getting less or increases.
Oh,
But so far, I have been seeing like over 100 cases. It's pretty good without doing the surgery.
surgery just by
Yes,
medicine.
yeah,
Awesome.
for the medicine. So it's impressive, very impressive.
Awesome. Yeah, because if they do go for surgery, do they just remove some of that thickened muscle then to
Yes,
to
yes.
get rid of the obstruction then?
Yeah, so for the myectomy, they only just cut off the thickened interventricular septum.
Okay,
That's all the surgery it is.
awesome. Let's see. So you have a few cases here.
Mm-hmm.
Can you talk about this case with the 88-year-old female?
Okay. So this one is like very, very classic one. So she just had like a short breath. That's the only reason she come to the ER. And then so for her family history, her mom diagnosis with heart disease like congenital
Congestive heart failure?
yeah, heart failure. Yeah, that's all the information I had. So the picture I just showed, sorry, I don't know. Only you and me can see it, right? It just to show very classic images to like what is HCM looks like. But
Okay.
the interesting thing is she's not only having the LVOT obstruction, she also have severe aorta stenosis.
Ah,
Yeah, so the thing is how differential between aorta stenosis and the LVOT obstruction. That's how why I want to show these cases.
okay.
Yeah. So when we scan it, so I found the LVT obstruction is the gradient, the highest gradient without Valsalva is over 100 millimeter of mercury.
Is
But for the
sorry,
yeah,
what?
for the yes, for the it's very high. For the
Okay.
aorta stenosis is it's like the highest velocity is like 3.1 meter per second.
Okay.
So it's just a very, very tiny movement of the cursor.
Right.
Yeah. So and then you can tell the difference. And also, you can use the EKG help you up. So
Oh,
for the aorta stenosis, it's a little bit later than the LVOT obstruction.
okay.
Yeah, so that's also the
It happens later in the PQR.
yes, a
Okay.
little bit later. Yeah.
Okay.
So MR come first, LVOT obstruction come the second, and the aorta stenosis should be later than both. But
Okay.
yeah.
Yeah, that makes sense. Awesome. So her treatment was to do an ablation of the septum.
Yes. So she had the septal ablation. Sorry, I forgot to mention before. So for the HCM patient, if they do not do the open heart surgery, they also can do the septal ablation too.
Okay.
Yeah. So this patient, she just had a septal ablation. She didn't do any aorta stenosis surgery yet. I don't know. Maybe they are considering do this first,
Right.
and then they do
Right.
the
So is the
cover thing.
ablation done in interventional radiology under
Yes.
cardiac cath?
Yes, you're right. And we also go there too.
Right.
So we also go there and then we took the picture, show them when they eject the contrast, show
Okay.
them where it is, and then the cardiologist just standing next by us. And they also read the picture too, and then they tell the surgeon how to do that.
Okay.
Yeah.
And where it's at and different things like that.
So it's like they try to find out uh which way because I think for the catheter they are go to different artery, I think. They try to make sure when you do the contrast, they want to make sure they are at the right spot. And
Okay.
then they eject the alcohol to do the septal ability.
Ah, nice.
Yes.
So they can be much more specific.
Yes, and also for patient who had a septal ablation, for the first 2 weeks, it's kind of the same. You just need to have the weight until the muscle becomes thinner. Yeah, this
Okay.
cannot like come out right away like the surgery you cut them off. You need to give
Okay.
them some time to process.
So there's like healing then that takes place of that septum that they've burned away. And so
Yeah.
it takes time for that to heal over before you can actually see the progress of it.
Y-
Correct?
Yes, correct. Because the cardiologist will always order the echo So we always go right after they having it. But we can compare like the after the patient had an ablation 1 week, after 2 weeks, how different it is. The gradient is progress is
Okay.
reduced. Yes.
That makes sense.
Mm-hmm.
That makes total sense. So tell us about oh, I think I skipped a patient. This 51-year-old female who presented with progressive symptoms of shortness of breath, chest pain, fatigue, and lightheadedness.
Mm-hmm. So actually, for this case, we also find out the patient has LVT obstruction. But the interesting I want to show this case is, this is good. Like the tip help sonographer when they scanning the patient because this patient she had also has significant LVT gradient. So she has very, very severe secondary mitral valve regurgitation. So when I scan through her five chamber of the apical, I really cannot get away between the mitral valve regurgitation and the LVT obstruction. So the patient is kind of like skinny. So her right peristernal lung axis view is fantastic. So what I do is I try to go to between the standard LVT, no, the standard peristernal lung axis
Okay.
and the right peristernal lung axis between those two windows.
Okay.
And then what I do is I made the heart go to like this. And
Okay.
then I use the cursor cross the ascending aorta.
Okay.
For that way, I can completely get away from the mitral valve regurgitation, but I can get very nicely LVT obstruction
Okay.
through the aorta. So for that way, I kind of have a good idea. Okay, what is the patient's LVT gradient looks like? At least cannot lower than this when I go to the five chamber. So that's how I kind of get an idea. Okay, the gradient is, for example, is 90. If I go to the five chamber, use the cursor cross the five chamber through the LVT. If my gradient is lower than 90, I know I need to find another window
Okay.
because even here I already find a higher velocity. It shouldn't lower at the five chamber or three chamber because it's more parallel. You know what I'm
Okay.
saying? Yeah. So that's also a good tip to help us to differentiate the mitral valve regurgitation and the LVT obstruction.
Awesome.
Yeah.
Yeah, the angles are really tricky when it comes to echo, right? Because it's I'm in high risk OB, and so angles, we have a big window of that whole uterus, and we can go all over that belly. But in echo, you're very specific to just sometimes even millimeters, right?
Yes.
Of
Yes.
angling of your probe and different things to get there. So I think this is why there's more injury in echo because of the very fine movements that you're making in order to get the correct angles, right?
Yes. I agree.
Yeah. So, yeah, it's hard to get that mitral valve flow out of the way sometimes when you're wanting to get to that LVO. So these are good tips to know, position of the patients, right? And position of your probe and your windows that you're using.
Mm-hmm.
Oh, I love it. So let's talk about case three, a 53-year-old female, and her son had hypertrophic cardiomyopathy, and she had an echo in 2001 that showed a septal thickening and an EKG 2 years ago that showed LVH. So her reason for the study was hypertension, chest pain, and shoulder pain. And tell us what you found with this study.
Okay. Can you give me 1 second? I think my internet has a little bit
Oh,
problem.
sure.
Thank you for waiting.
Oh,
So
sure.
this patient, yeah, when she coming, I scan her at the peristernal lung axis. I can see very thick interventricular septum. So I already kind of like, okay, this might be HCM patient. So I literally just put the color on the LVT. But the surprise thing is I didn't see any significant turbulence through the LVT. So I just do the same thing like what I just talked. I make her heart go to like this way and put the cursor across the LVOT, I
Right.
do not see any like very high velocity through that LVOT. So I directly went to the five chamber. When we zoom out the LVOT obstruction, we put the pulse wave from the apex and it's like slide down until we catch the LVOT, right?
Right.
So, and then when I put the color on, I can see very, very significant turbulence in the LVOT cavity. Very big turbulence. And no turbulence through the LVOT part or no significant mitral valve regurgitation. So I even rotate my transducer, go to the two chamber, and when I put the collar on, it still have like very strong turbulence in the LVT cavity.
Okay.
So yeah, I put the cursor in. It's very high density profile in the LVT cavity, but it's not LVT uh gradient. When patient is hyperdynamic, when
Right.
we put the cursor through the cavity, you
Right.
can see very late high gradient and very late in the EKG, uh, late timing. So, but you can tell it's kind of drag profile. It
Ah, okay.
looks like similar LVOT obstruction profile. It's like dagger profile, but it looks like not dagger, not that obviously dagger profile, but it looks like mitral regurgitation too. So I was so confused. Like
Ah,
what's happened on this patient is not LVOT obstruction, it's not LVOT hypertension, not LVOT no, left ventricle cavity gradient. So
okay.
what is that? So they end up send the patient to do the TEE, and then
Okay.
they diagnosis the patient is papillary muscle, uh, like a left ventricle papillary muscle obstruction.
Ah,
Yeah, it's the papillary muscle uh block the left ventricle tract.
okay. The
Yeah,
pulmonary
make the
muscle.
patient has short breath. So
Okay.
she end up kind of the sum of the papillary muscle, which is very interesting.
Yeah.
Yes.
Huh. So do you think she's had that for a long time or?
I do think so. She had that long time because
Okay.
when she had the echo before, not as Tufts, I think they just misdiagnosis. They try to
Oh,
focus on reduce her high blood pressure, but she's still having that symptom. That's why she transferred to Tufts.
okay.
Yeah, and
Oh,
also after she had the surgery, she had the echo again, and then like all the turbulence, all the symptom is gone.
ah.
Yeah. So it's
So
very
how did they
interesting case.
treat that then?
They did the surgery for her.
Oh, okay.
Yeah, they did the septal myectomy with
Okay.
release of the papillary muscle attachment
Okay.
and the resection of the abnormal connection to anterior mitral valve leaflet.
Ah,
Yeah.
interesting. So not good to assume, right? Investigate,
Yes.
investigate, investigate. That's awesome.
Mm-hmm. I think
Cool.
just because her papillary muscle is so large.
Ah, yeah,
Yeah. Mm-hmm. And the picture is very fuzzy because her interventricular cavity is small too. So you just see a lot of like something inside, but you cannot see very well.
yeah.
Yeah.
Huh. That's interesting.
Mm-hmm. So, yeah, I
Hmm.
think it's very very tricky. Like left ventricle cavity gradient, LVOT obstructions, and aorta stenosis. Those disease, what if they happen at the same time? How can you differentiate all of them? How can you take the picture to show the cardiologist the patient
Yeah,
has all of them? That's very, very tricky, and you need to have a lot of experience and skill to, make the patient go to different position and take the picture to show what you see.
right.
Yeah.
That's amazing. Well, I think we're going to stop with that. This has been wonderful to understand the differences and to be really specific and with your probe placement and patient position.
Thank you.
And I think this has added a lot of value to our audience. So thank you so much for sharing.
Of course, it's my pleasure. Thank you for inviting me.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.